needs to know about coronavirus. I'm really honored that everyone is joining us this evening. It really is an unprecedented time. We're all working from home and self-isolating at this point in time. So I'm really grateful to the entire IBD community for being here. And I'm especially grateful for our presenters this evening. They both are working in healthcare and taking time away from their practices and patients to be with us this evening. So I am truly honored to be introducing Dr. Andrew Grossman, who's a pediatric gastroenterologist at Children's Hospital Philadelphia. He's a member of our National Scientific Advisory Committee. He's the chair of the Pediatric Affairs Committee. And Andrew, thank you for joining us this evening.
Thank you for having me.
And I'd also like to introduce Dr. David Rubin. Dr. Rubin is an adult gastroenterologist from the University of Chicago Medicine. He's on our National Scientific Advisory Committee. He's the chair, a member of our Government and Industry Affairs Committee, and he's the incoming chair of our National Scientific Advisory Committee. And Dr. Rubin, thank you for joining us this evening as well.
Thanks, Laura, and thanks to the foundation for putting this on.
Thank you. It's our pleasure. And, you know, these are really challenging times for our patients. And I wanted to start out by providing some clarity on what's the difference between SARS-CoV-2 and COVID-19. And is COVID-19 the same as coronavirus? Dr. Rubin, would you mind addressing that for us?
Sure. Let me start by welcoming everybody tonight. And I'm sure that we share in your angst and anxiety and concerns about everything going around the world right now. And we are here working together, and we will get through this together. And I hope that tonight is going to be very informative. I'll start by just clarifying what I think has been confusing. There's a distinction between the virus that is causing a disease and the outcomes of the disease. So allow me just to take a minute to educate everyone. What we have been talking about is a novel coronavirus, a new type of coronavirus. A virus is not a bacterium. You don't treat it with antibiotics. A virus exists and replicates inside of other cells. And this particular coronavirus is a variant of other coronaviruses that have appeared and have been seen in humans and in animals before. This is a new type of coronavirus, and it's been given the name SARS-CoV-2. And that's because the first coronavirus that entered the human population and caused problems was something called SARS-CoV in 2003. SARS stands for Severe Acute Respiratory Syndrome because it affected the lungs. Subsequently, there was another coronavirus which caused something called MERS-CoV, or Middle Eastern Respiratory Syndrome, and that's because it appeared in the Middle East at the time. That was in 2012. Both of those viruses were actually quite significant because they had a much more significant mortality rate. Up to 60% of people who were infected with those coronaviruses died. This particular coronavirus, thankfully, doesn't do that. And the reason it's become such a problem is because many people have it and have no symptoms, and many people may have it and have no symptoms early and still be, we think, infectious. So the name of the virus is called SARS-CoV-2 because it's similar to that respiratory syndrome coronavirus previously described, and it has the number 2 because it's the second one like that. When SARS infects people, most, as you may know, have no symptoms or have a very mild course and get better. Some develop a disease called coronavirus disease, or COVID, and it's named COVID-19 because it was first described in December of 2019. So there's a distinction between having an infection with the virus and developing the disease. And some of what Andrew and Dr. Grossman and I will be talking about tonight will be distinguishing between getting an infection with the virus and developing the COVID-19 disease. So hopefully that starts to give people clarity a bit more. Now, I just want to make one other point, which is that SARS-CoV-2 is what's called an RNA virus. There are other RNA viruses, and we do have vaccines against RNA viruses, but the more common viruses that we see are called DNA viruses, and that would include hepatitis B, herpes, the chickenpox virus called varicella, CMV, Epstein-Barr, which causes mononucleosis. So you get the idea. So I just wanted to try and get some terms out there tonight so people understood where this came from and how it got these names.
We really appreciate that because I do think there's a lot of confusion between the different terms being used. So thank you for that explanation. Dr. Rubin, would you also tell us what the symptoms of COVID-19 are and what are the symptoms that IBD patients can expect? Is there a difference?
Right. So good. First of all, it's important that we're talking about the symptoms of the disease because you can have the virus and have no symptoms, and then we don't call it the disease. When people develop the COVID-19 condition, the most common symptom is fever. In fact, 99% of the patients described in the early experiences from Asia and subsequently had a fever. But then more common as well would be respiratory symptoms. People have a cough or they have some nasal congestion or a sore throat. And very important to our patients with inflammatory bowel disease is that some patients will have digestive symptoms. In the early reports from our Asian colleagues, we learned that about 10% of patients had diarrhea that accompanied their other respiratory symptoms. There's a paper that made the headlines, and many of you may know about, that recently suggested that up to 50% of patients would have digestive symptoms along with having the COVID-19 regular symptoms. Most of those also had fever, and most of them also had respiratory symptoms. So for our patients with Crohn's disease and ulcerative colitis, or ileostomies, or J pouches, if you have diarrhea, which we understand, or abdominal pain that may be part of your inflammatory bowel disease, the key here is, do you also have a fever, respiratory symptoms, or are your symptoms different than what we usually see, where we might suspect that you have COVID-19? So it's important to keep all that in mind. Additional symptoms that are less common would be feeling fatigue, which is of course non-specific and common in IBD as well. Having muscle aches or feeling a headache. Those are other symptoms that have been reported and you should keep an eye on if you develop them.
Thank you. Dr. Grossman, can you tell us how COVID-19 presents in kids and young people? And do children with IBD present differently?
Right. So Dr. Rubin really did a great job in helping us understand what the common symptoms are, and a lot of that is from the information that we have in adults. Much of the information that we currently have is in adults because right now this does seem to be a condition, the COVID-19, that is affecting adults more than it's affecting children. There are limited reports, and 2 papers came out in the last week describing the pediatric experience with this out of China. And different than what was seen in adults, a large percentage of children were actually not with symptoms. Less than 50% actually had fever. So as Dr. Rubin highlighted, a big presenting symptom of COVID-19 is fever, but of those children who were tested in China, less than half had fevers. Another major symptom that we are seeing in adults is the respiratory distress, not just some respiratory symptoms like cough and congestion, but also it progresses to respiratory distress. Of note, much fewer, 5% of children who were diagnosed with having a positive coronavirus test showed to have respiratory distress. So it does seem to be affecting the lower respiratory symptoms, the lungs, less in children, and it does seem to be affecting the upper respiratory system, nasal congestion, cough, runny nose, more in children. As far as the GI symptoms that Dr. Rubin just mentioned, we assume that it would be similar in children, although admittedly we have such limited data in children at this point that I don't think we can answer that definitively, but at this point we would assume it's similar. So what that means is that a number of things. One is because the course seems to be much less mild when a child gets this virus, we might be underestimating the number of children who have the virus, and that's because most people are only getting tested if they have symptoms. 2, there is some thought that children may carry the virus longer in the upper respiratory tract, in the nasal area, which means that they can be asymptomatic carriers. They can give the virus to others but not actually have it. So that is one concern in pediatrics. As far as children with IBD, as we'll discuss a little later, we have very few children with IBD who have been reported to have this, thankfully, so we don't have much data to provide.
So people may be wondering how and why patients develop respiratory symptoms and digestive symptoms, and it has to do with how the virus gets into our bodies and how it's transmitted from one person to another. The virus enters cells. Remember, I told you that the virus replicates and does its damage by being inside of our cells. It enters through the lining of our respiratory tract and also in the lining of the digestive tract. And there's a receptor on cells of those linings that allows the virus to gain entry. And there's lots of good research going on looking at that receptor. And so, first of all, that explains why people develop the respiratory symptoms, because that's where that receptor is expressed, but also that's how people get infected. They touch something, or they breathe in or inhale the aerosolized viral particles from somebody who has it already and is contagious. We often touch hard surfaces where the virus may be remaining for some period of time, and then we touch our face. And then secondarily, our digestive tract is really connected to our respiratory tract. We're swallowing things that we inhale all the time, and we believe that the virus enters through those main tracts. In fact, your lungs, your skin, and your gut are exposed to the environment more than any other part of your body. So it makes sense to think that the virus could get in through those different portals of entry and then cause some problems. And there's ongoing work looking now at the virus being in stool and whether or not a secondary transmission may occur from fecal material, which obviously is very important to us to understand. To reassure folks, the amount of virus detected in stool is orders of magnitude less than what's detected in the oropharynx, but we really don't know the time course of how long that stays there and how long it may be continued to be, if at all, infectious from the stool. So obviously hygiene in all that we do right now is one of the key features of how we can stop this and prevent you from getting infected.
I really appreciate you emphasizing that point at the end, Dr. Rubin, because, you know, it seems so simple to tell people to wash their hands, but it really is a preventative measure that we all really need to be taking to heart and doing frequently and for the appropriate duration. So thank you. I know one of the big concerns, especially of the IBD community, is for individuals on immune suppressing drugs, biologics, and biosimilars. Dr. Rubin, are there recommendations you have for individuals on these immune suppressing drugs, biologics, and biosimilars that you can share?
Well, the reason our inflammatory bowel disease community has been so concerned about this, in addition to the rest of the world, really, but our specific population is because, of course, we treat many of our patients with IBD using drugs that modify or suppress our immune system. I wanted to take a minute just to remind everyone why we do that. Inflammatory bowel disease is a condition of an overactive immune system. In general, what happens when you develop ulcerative colitis or Crohn's disease is that the immune system of your gut, which is a very sophisticated immune system, is either being continuously stimulated by something we have yet to figure out, or you've lost the ability to regulate it. So when it gets turned on, whether it's from an infection or something else that happens in your gut, your body is having difficulty shutting it down. Because we don't know the cause of IBD, we do treat the result of it. And frankly, that's what we do for most human diseases. We treat the result of the inflammation, which is we see an overactive immune response, and therefore the most effective therapies we have so far have primarily been aimed at modifying the immune response. So first, for everyone to remember, inflammatory bowel disease is a situation where your immune system, in most cases, is overactive. So your immune system is not suppressed at baseline in IBD. The treatment goals for inflammatory bowel disease are to use immune-based therapies to turn it down long enough so your body can take over and reset itself. Healing of the bowel happens not from the drugs directly, but indirectly when we take away the inflammation and allow the body to heal. That's a very important point, so that you should understand When we use these therapies, it's not our goal to suppress your immune system. It's our goal to modify that overactive response. So you're on treatments in many cases that are there to reduce the overactive immune system, allow the body to take over and heal, and to control damage that can occur from uncontrolled inflammation. Ideally, we use targeted therapies that reduce that overactive response and therefore control the disease and keep you well. Of course, the consequence of not knowing exactly how to do this perfectly is that some patients do have an increased risk for infections. We know that about our therapies in general. And the therapies that can do that are the ones that affect your immune system. So just as a brief reminder, some of the treatments we use for inflammatory bowel disease do not affect your immune system as far as we understand, like the aminosalicylate or the 5-ASA drugs, or antibiotics, or dietary therapy, especially in pediatrics when we use nutrition to treat, and Dr. Grossman can speak to that. But the therapies that we use that modify your immune system, like your immunomodulator therapies of 6-MP or azathioprine, or our biological therapies, like the anti-TNF drugs that some of you are on, infliximab or adalimumab or golimumab, or some of the newer biological therapies like vedolizumab or ustekinumab. I know these are lots of long names, but they all have different functions. And in general, what we've come to understand during the COVID-19 concerns is that we haven't yet seen a spike of concern in the IBD population. This may be because the way we're using these drugs is only turning down an overactive response and not actually suppressing people more than we think. There's also some very interesting work that suggests they may actually be protecting you. So remember, I told you that one of the portals of entry for this virus may be the gut. Well, having an inflamed bowel actually may make it easier for the virus to get in. And when people are taking their therapies and under good control, they may be doing well. So it's important for you to first understand why you're on your therapies, why the recommendations so far from different societies, including our foundation, have been to stay in remission and stay on your medicines, and to be reassured to understand a bit more about the drugs that you're taking. There are some interesting discussions going on right now that even suggest that some of these therapies may prevent complications from COVID-19, because the damage that occurs to the lungs that leads to the worst outcomes is related to an overactive immune response. So the same concept of controlling that overactive immune response may actually protect some of our patients with IBD. And of course, we're collecting data and looking for all the clues we can so that we can give you the best advice. Right now, our understanding is staying on your medicine is what's safest for you.
Thank you. Dr. Grossman, do you have anything to add for the pediatric community?
So I think that was an incredibly thorough review and explanation of how the drugs work, why it's important to stay on those, and how there may even be benefit. And we do think it's very similar for the pediatric community. Everything that Dr. Rubin just stated really does apply to children and adolescents as well, and as well the very young children with what we call the very early onset inflammatory bowel disease. We do feel that it is incredibly important that all children with inflammatory bowel disease try to maintain remission or stay in remission with the medications they're taking. We do use all of the same medications that Dr. Rubin just highlighted. We are recommending to our patients to continue those medications, to stay on schedule. The risk of infection that has been highlighted previously in adults on these medications actually does even seem to be lower in children. So we are as reassured as Dr. Rubin and his adult GI colleagues are. And I think the bottom line is we really want everyone to try and keep their gut healthy. The best way to be healthy during this period is to keep your Crohn's disease or your ulcerative colitis under control. Dr. Rubin did also mention nutritional therapies. So we do use nutritional therapies more in pediatrics perhaps than are used in adult patients. This includes having a diet for a period of time that is comprised mostly or exclusively of formula, or other diets which are often employed to help decrease intestinal inflammation. As long as you are promoting good nutrition, which these diets often are, we would want you to continue any nutritional therapies that you are currently on or considering. And it does go to that point as well, that maintaining good nutrition during this period is important to your intestinal health, your overall health. So we would add that as well as continuing your medications.
Those are really great points. And I want to add that we have lots of ways to monitor the condition of the bowel and the condition of the inflammatory bowel disease without having to do procedures. And if you want to know if your disease is under good control, or if you want to know that it's staying where it needs to be, talk to your healthcare teams, and they can arrange blood tests or even stool markers to know that your bowel is doing well. And that's how we monitor our patients now. And I think that this particular crisis has really raised the importance of using non-invasive markers to better understand how we're controlling the disease properly. So it's really important. I think that message needs to be driven home over and over again. People should stay on their medicines. The one exception that we should point out is that prednisone at higher doses appears to not be good. We know that it's not great for IBD in general because it doesn't sustain or heal the bowel. So ultimately people have problems. But we've also learned from this original SARS epidemic that prednisone did not work and made patients worse. So if you're on high doses of prednisone, meaning more than 20 milligrams a day, you should be talking to your team and figuring out a way to get down on that dose as soon as you're able. And of course, we have lots of different options to do that. I didn't want to leave out any therapies. We've covered lots of them. I know people are on different treatment combinations and regimens. And the general message across all of our therapies right now, and this is including some international conversations we're having, is to stay on your medicines. And when you're not sure, please do reach out to your physicians. Don't stop things without knowing what the status of your disease is and making sure you fully understand the implications of doing that.
And a reminder, Dr. Rubin just made a really good point about prednisone. And if you are on high dose prednisone, he recommended getting in touch with your healthcare team. An important reminder for anyone who's been on prednisone or is on prednisone, stopping it without actually tapering it has its own health consequences. It's very important to not stop without talking to your healthcare team. So please consult with them.
Good point.
And I'll just add, if anybody has missed the medications that we just talked about, all of this is on the Foundation's website and our COVID-19 pages. So please, take a moment, visit those. We reiterate these key points on those pages. So they'll be available to you now and after tonight's call as well, our Facebook Live.
Laura, there's been some other questions related to this that I might just mention so that we hit the topics. One of them is
absolutely
whether patients who are on receiving infusion therapies, is it safe to go to an infusion center to get your infusions? And the recommendation is that you should know that the infusion center has a screening protocol to check patients at the door for any symptoms that would suggest they may have COVID-19, including fever, of course, and the other symptoms we've discussed tonight. You should make sure that when you're there, there's adequate social spacing between everyone. At least 6 feet is what's recommended. And in some places it's appropriate. And I would suggest that you and the infusion team be wearing masks, which also reduces transmission of anything from one person to another. So in general, we think that's okay. Home infusions may be safe, but there's the added variable of a nurse who goes from house to house delivering therapy. And of course, we need to make sure that that's just as safe, and we have to be careful. The Foundation, through their advocacy efforts, is actually working now on a variety of very important issues, one of which is to try and loosen restrictions on home infusions as a therapy mechanism. And the other question that comes up is whether people who are on infusion-based therapies with infliximab might switch to the injectable versions of that same class of therapy instead, so they could do it themselves at home. That is of interest, but the previous work that looked at that didn't actually show that it was as safe as we'd like it to be. But I'm sure there are specific examples where that might be an appropriate option for people to consider. You just have to make sure your disease is under control and that you talk to your doctors about how to do that properly.
Thank you for making those points, Dr. Rubin, as well as highlighting our advocacy work. That's greatly appreciated. Another issue that comes up and is often in the realm of our advocacy work is drug shortages. Is this something our community should be concerned about?
Dr. Grossman, do you want to start with that one?
Obviously that has been something that has come up in the popular press. Having spoken with multiple partners in industry and some of our partners at the companies who do produce these medications, there has been concern regarding this. However, they have reassured me that their supply is strong, and to date, I am not aware of any shortage that is affecting or seems to be soon affecting patients with inflammatory bowel disease. But I am speaking mostly for where I'm practicing in the northeastern United States, and I believe that to be the case for the United States. But I want to defer to Dr. Rubin, who has also the international perspective and is working with these companies as well on a national.
Yeah, I agree completely. I've been in touch, or I've heard directly from a variety of the different companies to reassure us their production is fine. Their stores and stocks and their people are working, and everything is as we would expect it to be. So do not fear that. We could talk about whether or not there's going to be a shortage of toilet paper. I think that's a relevant question tonight for reasons that are not entirely clear to everybody. That seems to be something everyone wants for their time at home. And in all seriousness, the medication issue is not one people should worry about. It's not unreasonable if you're on a stable maintenance therapy to ask your healthcare team whether you can get a 3-month prescription instead of a 30-day one, but that's not because we're going to run out. That just makes sense in many other ways. And hopefully we're going to start to see some loosening of the restrictions on getting meds refilled, et cetera. Don't worry about that right now.
Thank you for that reassurance, because it does come up a lot, and it's good to know that the IBD medications are not being impacted by any shortages. I'd like to present a scenario to both of you. If a patient's scheduled to have a routine colonoscopy in the next 3 weeks, what would you recommend? Dr. Grossman, I'll start with you, and then Dr. Rubin, would you follow up?
So the question was regarding a routine colonoscopy, which to me means that very typically a routine colonoscopy is an elective procedure. And most institutions, if not all at this point, are postponing elective procedures. We made a decision to do so over a week ago, and that is for the foreseeable future. As a matter of fact, even some states have mandated that all elective procedures in those states have to be postponed. Dr. Rubin made a really good point earlier, and it really is emphasized by this question. In 2020, we have the ability to disease monitor in a very effective way without being invasive when we need to. We can use labs. You can communicate with your healthcare team. There are even stool studies that can be tested. At this point, a routine colonoscopy from a risk-benefit ratio, we would recommend not doing that elective procedure. The question that sometimes is a little harder to determine is if someone is having very active symptoms, whether it be bleeding or other symptoms where there's a question whether there needs to be a more acute intervention, then there needs to be a discussion with the healthcare team. But at this point, the majority of procedures, particularly in pediatrics, are being postponed.
I completely agree. Some who are joining us will know that the Surgeon General actually weighed in on this and recommended that all elective procedures be postponed. There was some pushback as to how you define elective, and I completely agree with Dr. Grossman that in our IBD world, that usually means assessment of disease activity, which we can now do in many other ways that are emerging and are being used regularly, or screening and doing surveillance exams to look for precancerous changes. So my point here, and I actually tweeted about this yesterday, is that if you delay these exams, which is recommended right now and totally appropriate, you should make sure that you keep it on your to-do list. And I've told all my colleagues to make sure they keep a list of all their patients so that you don't miss your screening and your prevention exams that are supposed to be done regularly. We don't want the second or third wave of illness that comes out of all this to be people who missed their screening exams when they could have had a good exam done properly. So make sure you keep a list of all the things you're putting off now that you should definitely get back on track for in the fall when this is all past us, God willing, and when we can move forward together. I also want to point out one other thing, which is that the reason this is all being recommended is to preserve the personal protective equipment that all the healthcare providers need, and also to keep you safe, to not bring you to a healthcare center when you don't need to be there, to reduce the need for all the different resources that go into that kind of visit, and to not expose you inadvertently to someone who may be walking around with the SARS-CoV-2. So there's lots of different reasons this should be done. That doesn't mean that the more urgent cases can't be done. Of course, we're open for business to do that and to take care of people as they need. So don't delay if you really need something, and certainly don't be living at home in fear of calling your doctor's office or your nurse or your advanced practice providers or any of the important members of your healthcare team. They're all waiting to hear from you, and we're all doing the best we can to make sure we address these things.
It's such a good point with these other health concerns, national health concerns that we're hearing. Yes, we are still here. We still want to hear from you. We are here for you, excuse me. The other thing, speaking of unique ways of monitoring or of communicating, I know at Dr. Rubin's program and ours as well, and many other clinics and hospitals and programs are able to now offer telehealth visits, where you can actually conduct a almost like a visit you have in the office with your healthcare team via video. And you should look into whether your providers are capable of doing that. I've now done several of these and have found it to be quite helpful. We have the opportunity to see each other, really a better way to assess than just a telephone call if available, and could be another useful modality in communicating with your team and us really understanding what's going on with you and seeing how we can help.
I think that's a really important point. And just as we're using technology tonight, we're able to use it in the healthcare setting now as well. So thank you for all of those points on how patients should be continuing to get screened, but use other methods and talk to their doctors and nurses via their portals, telephone, and virtual visits. I have a question that I think is really important as we're all self-isolating and social distancing. Dr. Rubin, I'll start with you, and Dr. Grossman, then I'll turn to you. What tips are you giving your patients who are working from home? And Dr. Grossman, what tips are you giving your patients who are doing school at home?
Well, for this question, I actually asked my wife for help because we're all here. And of course, I'm still working in the healthcare arena, but my 2 college-age sons are home. And my wife is home and teaching from her computer in the kitchen, the preschoolers. And so I asked for some advice from all of them. And we came up with a short list, and forgive me if this is already known to many people out there, but the first was make sure you maintain a routine. It's going to be a new routine maybe for you, but keep the same type of routine where you're going to get things done every day the way you might normally and stay on track. Secondly is how important it is to reach out to family and friends, to stay in touch with people just like we're doing tonight, and think about friends who may need you or who might like to hear from you. Reach out to family members who you may be worried about, and make sure you talk to them regularly and reach out to them, because we have the benefit of technology now to do so effectively. The third piece of advice was to try to get some exercise. That's hard when you're stuck in a house. Even with social distancing, you can go for a walk if you are careful about it and you maintain that distance. That doesn't mean go looking for crowds or congregate, but it does mean you can get some fresh air. You can also exercise in your home. I know many people have those equipment at home that they could use. The next piece of advice is don't leave your news on all day long. Don't get stuck to the computer or the TV watching the news all day. That can really drag you down, and that's not very healthy for our, obviously for our mental health, as well as many other reasons. And lastly, I would just say give yourself permission or even schedule to be unplugged for part of every day. There are other things you can be doing. Maybe this is the time that you want to get a project done in the house that you've been waiting to do, but you have to schedule it because it could be really easy to get into a rut. And then, of course, we want to make sure we're taking care of our mental health and all the other things that come out of all this as well. Many IBD patients have been posting on social media that they understand what it's like to be in isolation, and now the rest of the world is experiencing it. So they may have even better tips than what I'm giving tonight. And we certainly feel for all of our patients, and we're thinking about all of you.
I think those are the really excellent tips and very much what I would be recommending as well. So I have a 10-year-old and a 12-year-old boy who are home, who are now learning how to do school, elementary and middle school classes by these methods. And as everyone here who either is a child or has children knows, it has really been a learning process. It's been a learning process for the schools, for the teachers who are working so hard to make this work for the children and for the children and their parents. Everything Dr. Rubin said, I agree with. I especially want to emphasize the importance of having some form of schedule. We're waking up at a regular time. We are opening all the shades. We are making sure there is light in the house. We are making sure that we spend time together. You know, many of these children, these younger children, they are used to having a level of stimulation that suddenly has been taken from them, and that is difficult. We are trying to work from home while our children are trying to have class. You have to make time to spend with them as well to make sure you can help them when they have those moments. It's not always possible. It might not be every minute, but making that time. Taking care of yourself is very important. We all feel the stress right now to be doing as much as we can for everyone. But taking care of yourself is very important. And I really want to emphasize what Dr. Rubin said about disconnecting. Generally, many of us go to work, come home from work. We're now in a new paradigm where the work is at home. So sometimes it is harder to leave it. It's harder to disconnect, to close the computer screen, if you will. It's important to do that. And then lastly, remember, we've all been nervous about what is happening in the world right now. Our children are seeing that we're nervous. I think we're going to talk about this a little more towards the end of this session, but remembering that they're hearing it, they're seeing it, so make sure we're explaining things to them in a way that they can understand.
Yeah. And to both of your points, I think it's so important to stress the mental and emotional health and wellness of our IBD community. And the foundation will be doing some follow-up programs next week focused in on providing emotional and mental wellness for our adult and pediatric patients. So more to come on that. One of the harder questions are for those patients, those IBD patients who are considered essential workers right now, who can't work from home. Are there any additional insights that you can give the healthcare providers and those essential workers with IBD and the precautions they should be taking?
It's a common question, and I've also posted about this through Twitter, and I want to address it tonight. There are two issues to address first. For each individual who's still working or needs to be at work, whether they're a healthcare worker or not, the question is, what is your contact risk? In other words, what is the likelihood that you're going to be exposed to SARS-CoV-2 through your work? Now, for healthcare workers, that may be variable depending on whether they're on the front line or whether they're working behind the scenes and doing televisits. And for some who are essential workers who are not in healthcare, but who have frequent contact with the community, you can imagine that their contact risk is maybe even higher than our healthcare population of healthcare workers who are wearing protective equipment. So the first question is, what's your contact risk? And the second question is, what's your risk in general because of the therapies you might be on? Now, we've already tried to reassure everyone based on what we know that the majority of inflammatory bowel disease therapies are safe to continue during what's going on right now. We just made the point of high-dose prednisone as the exception. Everything else we think you should be staying on, even when you're in these situations. So whether you're a worker who is in frequent contact with people in your job or a healthcare worker on the front line where that risk may be higher, then there are a couple things to keep in mind. The first one is talking to your supervisor or your boss or your coworkers about ways that you might not be in that situation. Are there other tasks or jobs that could be created or that exist that you could be doing instead? Secondly, is frequent hand washing and meticulous hygiene. We keep bringing that up over and over again. Social distancing, even at your place of work when you do need to work, separating people out. You've even seen some of the panel discussions on CNN where they now have everyone sitting farther apart. That should be the same in your work if you have to be there and you're doing all that. Thirdly, for healthcare workers, we're getting to the point where we've been recommending that they wear just general surgical masks, not the particulate respirators that everyone talks about, but just general surgical masks whenever they're in the hospital setting doing different things. So that reduces the likelihood of any contact, but also reduces the risk they may inadvertently expose someone else if they become infected. So wearing a mask is reasonable for our healthcare worker population, and it might be reasonable depending on what your job is in your essential position to be wearing a simple surgical mask or even gloves. And so it's very important to explore first, what is the likelihood you're going to be exposed, whether it's community or in the healthcare setting? What are the options for you to do something else? And when you can't, taking all the precautions I just listed so that you're minimizing the risk. Meticulous hand hygiene and covering your face or your mouth actually reduces the majority of transmission based on everything we're learning now. And so this is something that you can and should be doing.
Dr. Grossman, do you have anything to add?
In pediatrics, not many of my or any of my patients are essential healthcare workers. A little off the topic, but since Dr. Rubin did really emphasize hand hygiene, a reminder to the parents of children that children need to be reminded to do this. It's not something that comes naturally, if you will, for many in pediatrics. So it'll be important to frequently remind children of that.
Yeah, that's a great reminder. I wanted to ask you both to share the latest research that's being done to understand the impact of COVID-19 on the IBD community, particularly emphasizing the secure IBD registry.
Why don't I start by saying that I'm very proud to be part of the inflammatory bowel disease community. Worldwide, the amount of collaboration and the speed with which our colleagues have come together is really enviable by many other specialties who have now turned to us and asked us how we did it and what we're doing to keep track of what's going on and to try to move forward to protect our patients and to understand this. So there's an organization called the International Organization for the Study of Inflammatory Bowel Disease, or IOIBD, and over 80 international experts on IBD have come together and are working on recommendations, some of which I've summarized for you tonight, and there'll be more coming. And very importantly, a group in the United States led by Dr. Michael Kappelman, Dr. Ryan Ungaro, and Dr. Erica Brenner have put together a registry, a worldwide registry for patients who have inflammatory bowel disease and develop COVID-19. Now, the registry is being filled out by the doctors and nurses who take care of these patients, but it is an incredible way for us to collect real-time data to learn what's happening all over the world. And so far, it appears reassuring. While we're not surprised at all to learn that some people with IBD have developed COVID-19, the total number since they've been collecting these data for the last 3 weeks is 41 cases, 10 of which required hospitalization. Majority of the patients have recovered uneventfully, and as you heard, 31 of these patients didn't even go to the hospital, and they've been on all the different meds that we already talked about tonight. So there's no signal yet to tell us. We learned in the early SARS epidemic that the meds that we have didn't also give a signal at that time that it was an increased risk. So this seems in line with that. It has also shown us that it's more men than women. Women are not protected and that doesn't mean they don't take the same precautions we've talked about, but for whatever reason, it's affecting men a little bit more than women across the world, not just in IBD, and that's important to understand. And because IBD affects young people and older, what we're seeing in these 41 cases is that it's all ages. It's sort of the spectrum of ages that you would expect otherwise, because people of all ages have IBD. So we're learning from this. It's very helpful information. And so far, it doesn't show us a spike in a certain group or anything that makes us more worried than we would be. I know Dr. Grossman can speak a little bit more about what they're seeing in children.
Right. So the secure IBD registry, which Dr. Rubin just alluded to, with the up-to-date number being 41 patients, only one of the 41 was under 20 years of age. So at this point, we really are not seeing a lot or many or really more than a handful of cases of this being reported in children with IBD. Now, remember, this was, when we talked about this earlier, we did discuss that often the symptoms are more mild in children with IBD, but as far as diagnoses that have been reported in this registry to date, only one has been pediatric. So we don't have a great deal of data on children with IBD, but we concur with what Dr. Rubin just said, which is so far the data is reassuring, and but we will continue collaborating and reporting any data that we uncover.
Thank you. And that's really important. And it's so reassuring to hear that there's research going on and that we're looking to find the trends for our community and to learn more on how we can treat COVID-19 in the future. So I wanted to ask you, what is the one thing you're telling your patients and caregivers during this difficult time? Dr. Grossman, would you like to start, and Dr. Rubin will end with you?
Sure. So clearly we're in a lot of communication and saying more than one thing, but the one thing that I think we would emphasize is continue to be in touch with us. We want to hear from you. We are your team. We want to ensure your highest level of health. Just because the clinics aren't as open as they were, or we weren't doing procedures, or the hospitals you're hearing are very busy worrying about fighting COVID-19, does not mean that your healthcare team is not available to you. We are available to you. We want to hear from you. As you've heard multiple times, maintaining your health, keeping your IBD in as good control as you can, is going to be of paramount importance. We want you to take care of yourself. For the caregivers who are listening, we want you to take care of those who you're taking care of, and we want you to let us help you.
Thank you. Dr. Rubin.
I think the one thing I would advise people is to make sure that the information you're getting is reliable. So, of course, I agree with what Dr. Grossman said. And I would just say that there's so much information available. You can absolutely go crazy reading all this. I want to make sure that people go to reliable resources. That includes your own physician and healthcare team, but I want to give a shout out to the Crohn's and Colitis Foundation with their dedicated website for coronavirus now, which many people I'm sure have come across in coming to this tonight. I would also refer you to the ioibd.org website, which has got an update on the coronavirus situation. And just out today, the American College of Gastroenterology also has patient information that a few of us came together to work on. You can read from, of course, from the CDC, the World Health Organization, but just keep in mind that those recommendations, which are very important, don't always apply directly to the IBD population. So when you're looking for things related to IBD, make sure you go where the people who are working on this directly are there to help you and answer. And we'll be updating this regularly. The story is not told yet, but so far I am proud of the people working so hard on your behalves and working together, and I know we're going to get through this. It's really important to keep that in mind. We will. There will be a vaccine. It's going to be longer than people might want. They're saying a year. There's going to be additional information about treatments for people who do get the disease, but there are going to be new ways to manage this, and we will get through this. And you know what else? We've learned so much about ourselves and about our world from this that I'm very optimistic about how the world will be moving forward together.
I really appreciate that final thought, Dr. Rubin, and that there is optimism and there is credible resources out there for patients and their caregivers to go to. And one of the things I just want to emphasize to our community tonight is we've tried at the Crohn's and Colitis Foundation to link out to all of the credible resources so that you don't have to go searching for the IBD information. It's right there on the foundation's website. Will drive you right to the resource in the page. So consider us your one-stop shop, so to speak, for all things COVID-19 and coronavirus related. And we do update our resources really on a daily basis as new information, as we learn from our experts here this evening, new information, new resources. We're constantly updating that material so that we can make sure you have what you need to engage in discussions with your healthcare team and with your family members, and also have the emotional support you need. So please reach out to the foundation if you are in need of someone to talk to. You have a question and you can't reach your physician, call our IBD Help Center. We're here to support you, and we'll provide you with a peer support person or connect you with a virtual support group. We've changed a lot of our events to virtual at the foundation, but we still have support groups and a community that is here to provide those resources to you during this challenging time. And I really appreciate both Dr. Grossman and Dr. Rubin for coming on the call tonight. I know how difficult it is that our physicians and our nurses and everyone in the healthcare community is working long hours right now taking care of patients. And we are truly grateful at the foundation to have both of you spending your evenings with us tonight. So thank you. And thank you to everybody out in our Facebook community this evening for joining us. Again, if we didn't answer your question this evening, please reach out to the foundation, and there'll be more education to come. This isn't our last Facebook Live. I'm sure we'll be doing more on this topic, and look out next week for our mental and emotional wellness resources. They'll be posted on the website shortly, as will the recording of tonight's Facebook Live. So thank you, everyone, and have a great evening, and take care of yourselves.
Thanks, Laura.
Thank you. Good night.
Good night.